Hello, my name is Dr. Christopher Pazanka. I'm the Corporate Director of Clinical Research at U.S. Urology Partners and Chief Executive Officer of Associated Medical Professionals in Syracuse, New York. This presentation will explore key considerations in the management of BCG unresponsive non-muscle invasive bladder cancer with CIS, highlighting the clinical challenges and unmet needs. It will also examine the indication, efficacy, and safety profile of INLEXZO, which is a gemcitabine intravesical system, with a detailed look at its mechanism of action, dosing regimen, and administration guidelines. Before we begin, INLEXZO is indicated for the treatment of adult patients with BCG unresponsive non-muscle invasive bladder cancer, also known as NMIBC, with carcinoma in situ, also known as CIS, with or without papillary lesions. Now for program disclosures. This is a non-accredited promotional activity. The program content was developed and approved by Johnson & Johnson. Speakers are compensated to present this information on behalf of the company and must do so in compliance with U.S. Food and Drug Administration, FDA regulations. Here are the objectives of this presentation. Overview of BCG unresponsive NMIBC with CIS considerations. Describe the mechanism of delivery of INLEXZO. Review the indication, efficacy, and safety profile of INLEXZO. Summarize INLEXZO dosing and administration, and access and office support for INLEXZO. This slide discusses the features of NMIBC. NMIBC is characterized by the inclusion of any of the features listed here. Characteristics of high-risk NMIBC are listed here on the right. High-grade T1, any recurrent high-grade TA, high-grade TA greater than 3 cm or multifocal, any CIS, any BCG failure in high-grade case, any variant histology, any lymphovascular invasion, any high-grade prostatic urethral involvement. On this slide, we see CIS is linked to worse clinical outcomes. NMIBC with CIS has increased risk of invasive disease and poor cancer outcomes. CIS manifests as a flat, high-grade, and aggressive tumor in the inner lining of the bladder. A retrospective cohort study of patients with high-risk NMIBC, a total of 412 patients, were treated in the VA system. It was reported a worse 10-year progression-free survival in CIS compared to non-CIS disease, 60% and 82%. In a study of patients with NMIBC containing CIS from 2004 to 2015, the cancer-specific mortality was 15.6% at a median follow-up of 124 months. BCG is a first-line treatment for NMIBC, but not all patients have a durable response. Patients are classified as BCG unresponsive when they meet at least one of the following criteria: persistent or recurrent CIS alone, or with recurrent TA or T1 disease within 12 months of completion of adequate BCG, recurrent high-grade TA or T1 disease within 6 months of completion of adequate BCG, or T1 high-grade disease at the first evaluation following an induction course of BCG. Adequate BCG is defined as greater than or equal to 5 of 6 doses of an initial induction course, plus either greater than or equal to 2 of 3 doses of maintenance therapy, or greater than or equal to 2 of 6 doses of a second induction course. Historically, about 40% of a study with 1,421 patients with intermediate and high-risk NMIBC treated with BCG developed recurrent disease. Recurrence data are from a formal meta-analysis of 11 eligible studies conducted between 1987 and 2000 in a total of 2,749 patients. CIS outcomes were only documented in 4 studies, and the number of patients was too small for a formal analysis. Overall, the median follow-up was 26 months. Additional options are still needed in BCG unresponsive NMIBC with CIS. As we see here, although radical cystectomy is a guideline recommended or preferred treatment option for patients unresponsive to adequate BCG, 86% of patients still do not undergo the surgical intervention. Radical cystectomy ineligibility and refusal data are from a retrospective chart review pulled from January to May of 2019 of 2,554 patients with BCG unresponsive NMIBC, which included patients from various countries, including 600 patients from the US. Additionally, most intravesical installations have a maximum of 2 hours of direct drug contact time with cancer in the bladder and require patients to hold the treatment in for 1 to 2 hours. Therefore, premature voiding of intravesical fluids may occur. When patients become BCG unresponsive, clinicians should consider additional treatment strategies. Let's take a look at a hypothetical patient case. James is a 68-year-old white male with NMIBC with CIS. James's treatment history shows he tolerated and received 6 weeks of BCG induction for a total of 6 doses, and over the next 16 months, he received 3 cycles of maintenance therapy. There was a repeat evaluation 10 months following completion of his last BCG, which confirmed CIS with high-grade TA disease. To highlight a few considerations, James lives an active lifestyle and did not want to consider a radical cystectomy. He noted that preserving his bladder is an important consideration for his next treatment choice. Given the details of this case, what should be the next step or steps of James's treatment, and what, if any, additional information would help guide this decision? Innovation has arrived for your appropriate patients with non-muscle invasive bladder cancer after BCG. Specifically, INLEXZO is indicated for the treatment of adult patients with BCG unresponsive NMIBC with carcinoma in situ, with or without papillary tumors. Let's take a listen to the INLEXZO important safety information.
Important safety information. Contraindications. INLEXZO is contraindicated in patients with perforation of the bladder, prior hypersensitivity reactions to gemcitabine or any component of the product. Warnings and precautions. Risks in patients with perforated bladder. INLEXZO may lead to systemic exposure to gemcitabine and to severe adverse reactions if administered to patients with a perforated bladder or to those in whom the integrity of the bladder mucosa has been compromised. Evaluate the bladder before the intravesical administration of INLEXZO, and do not administer to patients with a perforated bladder or mucosal compromise until bladder integrity has been restored. Risk of metastatic bladder cancer with delayed cystectomy. Delaying cystectomy in patients with BCG unresponsive CIS could lead to development of muscle-invasive or metastatic bladder cancer, which can be lethal. The risk of developing muscle-invasive or metastatic bladder cancer increases the longer cystectomy is delayed in the presence of persisting CIS. Of the 83 evaluable patients with BCG unresponsive CIS treated with INLEXZO in Cohort 2 of Sunrise-1, 7 patients, 8%, progressed to muscle-invasive, T2 or greater, bladder cancer. 3 patients, 3.5%, had progression determined at the time of cystectomy. The median time between determination of persistent or recurrent CIS, or T1, and progression to muscle-invasive disease was 94 days. Please stay tuned for additional important safety information later on in this video. Please read full prescribing information and instructions for use for INLEXZO on this website.
INLEXZO is the only FDA-approved intravesical drug-releasing system as of September 9th, 2025. INLEXZO is a sterile, non-resorbable intravesical system containing the equivalent of 225 milligrams gemcitabine, which is present as 256.3 milligrams of gemcitabine hydrochloride. INLEXZO contains an almost white to light pink brown colored gemcitabine component at the center, surrounded on each side by off-white to light blue colored osmotic components. INLEXZO provides prolonged local delivery of gemcitabine into the bladder for weeks, not hours. Of the total gemcitabine dose, 77% was excreted by day 7, and 99% was excreted by day 21 in the urine as gemcitabine and the metabolite DF-DU. INLEXZO is inserted via transurethral catheterization and removed via cystoscopy, which are familiar in-office procedures. Once inserted, INLEXZO curls into a bioval shape like a pretzel, which is designed to promote retention within the bladder. INLEXZO remains freely mobile in the bladder throughout the indwelling periods, even after voiding. Now here is a video that describes the insertion and removal of INLEXZO. As you watch the video, it's important to instruct patients not to empty the bladder immediately prior to the insertion procedure. This is because the presence of urine in the bladder can facilitate deployment of INLEXZO, and then patients can resume micturition after the insertion procedure.
The tip of the urinary catheter is lubricated, introduced into the urethra by hand, and advanced until urine return. After placing the urinary catheter, lubricant is injected. INLEXZO is then inserted into the urinary catheter by hand. Lubricant is then added again to help advance INLEXZO further. Next, the stylet is slowly inserted until the hub is flush with the end of the urinary catheter, to ensure INLEXZO exits the urinary catheter and enters the bladder. Finally, the urinary catheter and stylet are removed as a single unit. With the non-cutting, grasping forceps of a cystoscope, INLEXZO is grasped over the tubing and metal wire portions and removed from the urethra.
The slide here takes a look at the INLEXZO mechanism of action and pharmacodynamics. As for the mechanism of action, gemcitabine kills cells undergoing DNA synthesis and blocks the progression of cells through the G1 S-phase boundary. In terms of pharmacodynamics, the exposure-response relationship and time course of pharmacodynamic response for the safety and effectiveness of INLEXZO have not been fully characterized. Now we will discuss INLEXZO pharmacokinetics. In the mid-2000s, a hospital-university collaboration developed an intravesical drug delivery system to achieve prolonged drug levels in the bladder while avoiding systemic toxicity. Following the intravesical administration of INLEXZO, systemic exposure of gemcitabine was below the lower limit of quantification. As we see on the middle of the slide, 18 patients had at least one quantifiable plasma DFDU concentration above the lower limit of quantification, and the maximum observed plasma DFDU concentration was 0.4 micrograms per milliliter. Additionally, the mean urinary excretions on days 2 through 5 range from 21 to 32 milligrams per day excreted in the urine as gemcitabine and DFDU. Now let's take a look at Sunrise-1, the pivotal study that evaluated the efficacy and safety of INLEXZO. The efficacy and safety of INLEXZO was evaluated in cohort 2 of Sunrise-1, a phase 2b single-arm open-label trial in 83 adults with BCG unresponsive NMIBC with CIS with or without papillary tumors who had persistent or recurrent disease within 12 months of BCG completion. Patients were ineligible for or elected not to undergo radical cystectomy. Patients were considered BCG unresponsive. INLEXZO was administered every 3 weeks for 6 months, then once every 12 weeks for up to 18 months. Major efficacy outcomes were complete response rate at any time and duration of response. Mandatory biopsies were performed 24 and 48 weeks after treatment initiation, and reinduction was not included in the study design. As we continue to look at the Sunrise-1 study design, this slide will look at the key study definitions and considerations. Mixed histology tumors were allowed if urothelial differentiation, the transitional cell histology, was predominant. However, patients who presented with extravesical, muscle invasive, locally advanced, or metastatic urothelial carcinoma were excluded. BCG unresponsive NMIBC CIS was defined as persistent or recurrent CIS alone, or with TA or T1 disease within 12 months of adequate BCG therapy. Adequate BCG therapy was defined as at least 5 of 6 doses of an initial induction course plus either of at least 2 of 3 doses of a maintenance therapy or at least 2 of 6 doses of a second induction course. Complete response rate at any time was defined as negative results for cystoscopy with a TURBT or bladder biopsy as applicable and a negative centrally evaluated urine cytology. The duration of response was defined from the date of the first complete response achieved to the date of first evidence of recurrence or progression or death, whichever is earlier, for patients who achieved a complete response. Of note, the study design did not include reinduction for non-responders, but importantly mandated bladder biopsy at weeks 24 and 48. Disease response assessments included cystoscopy and central urine cytology performed every 12 weeks for up to 2 years, then every 24 weeks until the end of the study. Local imaging such as a CT scan or MRI was performed every 24 weeks until the end of the study, and a central pathology bladder biopsy or TURBT was performed at weeks 24 and 48 or as clinically indicated in the cases of a positive cystoscopy. The two charts here look at the Sunrise-1 patient characteristics. Overall, the majority of patients were white males with CIS only. Next, we will look at the efficacy results from Sunrise. As you can see here, the complete response rate at any time was 82%, with a 95% confidence interval between 72 and 90%. Complete response was achieved without reinduction. 51% or 35 of 68 evaluable patients maintained a complete response for greater than or equal to 12 months. On this slide, we see Sunrise-1 additional data. INLEXZO is designed for patients seeking bladder preservation. Key numbers to highlight here are 92% of evaluable patients did not progress to muscle-invasive bladder cancer, defined as greater than or equal to T2 disease. 3.5% of patients had progression to terminate cystectomy, with a median of 94 days between persistent or recurrent CIS or T1 and muscle-invasive bladder cancer. Looking at cystectomy data, 84% of patients who achieved a complete response did not have a radical cystectomy. It is important to note that delaying cystectomy can lead to the development of metastatic bladder cancer, which can be lethal. Another important point is that this was an exploratory analysis that is not in the prescribing information, and it is being provided for descriptive purposes. These results require cautious interpretation because radical cystectomy may have occurred after patients discontinued treatment. The median follow-up time in responders was 20.2 months, ranging from 5 to 48 months. As we continue to discuss the Sunrise-1 study, we will look at the safety profile. The safety population included 85 patients for evaluation. INLEXZO has a proven safety profile. Serious adverse reactions occurred in 24% of patients receiving INLEXZO. Serious adverse reactions that occurred in greater than 2% of patients included urinary tract infection, hematuria, pneumonia, and urinary tract pain. Fatal adverse reactions occurred in 1.2% of patients, including cognitive disorder. As you can see on the table, the two most common adverse reactions were urinary frequency, which occurred in 48% of patients, and urinary tract infections in 44%. Other adverse reactions in greater than 15% of patients included dysuria, micturition urgency, urinary tract pain, hematuria, and bladder irritation. The most common lab abnormalities that occurred in greater than 15% of patients are listed on this slide. They include decreased hemoglobin in 31% and increased lipase in 28%. Other lab abnormalities included decreased lymphocytes, increased creatinine, increased potassium, increased AST and ALT, and decreased sodium. Adverse reactions that led to permanent treatment discontinuation occurred in 7% of patients. They include bladder irritation, urinary frequency, cognitive disorder, hydronephrosis, and urinary tract disorder. ARs requiring dosage interruption occurred in 41% of patients. These included UTI, urinary tract pain, hematuria, urinary frequency, micturition urgency, dysuria, and genital pain. Let's take a look again at our patient James, who we spoke about earlier. James is a 68-year-old white male with NMIBC with CIS. James's treatment history shows he tolerated and received 6 weeks of BCG induction for a total of 6 doses, and over the next 16 months, he received 3 cycles of maintenance therapy. Repeat evaluation 10 months following completion of BCG confirmed CIS with high-grade TA. James lives an active lifestyle and did not want to consider radical cystectomy. Preserving his bladder is an important consideration for his next treatment choice. James is BCG unresponsive. Is INLEXZO a treatment option for him? We will now review the dosage and administration of INLEXZO. INLEXZO is administered in 14 doses over a 2-year period. Insert INLEXZO into the bladder once every 3 weeks up to 6 months for 8 doses, followed by once every 12 weeks for up to 18 months, or until persistent or recurrent NMIBC, disease progression, or unacceptable toxicity occurs. It is important to note that INLEXZO is intended to be removed after each 3-week indwelling period. INLEXZO is inserted by transurethral catheterization using the co-packaged urinary catheter and is removed by cystoscopy after the 3-week period. Cystoscopy and catheterization should be familiar procedures in your practice. Additional dosage and administration considerations are highlighted here. INLEXZO should be removed by flexible or rigid cystoscope and non-cutting grasping forceps. Removal of INLEXZO by cystoscopy provides the opportunity for simultaneous assessment of disease response. If a dose is missed, it should be administered as closely as possible to the original treatment schedule. Prophylactic antibiotics may be used at the discretion of the healthcare provider with each INLEXZO insertion and removal. INLEXZO contains a metal wire. Therefore, INLEXZO may be used with MRI only under the specific predefined conditions described on this slide to avoid potential safety hazards or severe adverse reactions. Let's review some important administration instructions. Here are some administrative considerations. Administer INLEXZO intravesically only. Do not administer by any other route. INLEXZO is co-packaged with the urinary catheter and stylet used to insert INLEXZO through the urinary catheter into the bladder. Administer using the co-packaged urinary catheter and stylet only. Do not use any other catheter. INLEXZO should be inserted and removed by a trained healthcare provider. Healthcare providers should become thoroughly familiar with the insertion and removal instructions before attempting insertion or removal of INLEXZO. Handling considerations. INLEXZO is a hazardous drug. Follow applicable special handling and disposal procedures while handling INLEXZO and during the insertion and removal procedure. It is important to read full instructions for use for complete information on preparation, intravesical administration, and removal of INLEXZO. Let's take a moment to review the important safety information for INLEXZO.
Magnetic resonance imaging, MRI safety. INLEXZO can only be safely scanned with MRI under certain conditions. Refer to Section 5.3 of the USPI for details on conditions. Embryo-fetal toxicity. Based on animal data and its mechanism of action, INLEXZO can cause fetal harm when administered to a pregnant woman if systemic exposure occurs. In animal reproduction studies, systemic administration of gemcitabine was teratogenic, embryotoxic, and fetotoxic in mice and rabbits. Advise pregnant women and females of reproductive potential of the potential risk to a fetus. Advise females of reproductive potential to use effective contraception during treatment and for 6 months after final removal of INLEXZO. Advise male patients with female partners of reproductive potential to use effective contraception during treatment and for 3 months after final removal of INLEXZO. Adverse reactions. Serious adverse reactions occurred in 24% of patients receiving INLEXZO. Serious adverse reactions that occurred in greater than 2% of patients included urinary tract infection, hematuria, pneumonia, and urinary tract pain. Fatal adverse reactions occurred in 1.2% of patients who received INLEXZO, including cognitive disorder. The most common, greater than 15%, adverse reactions, including laboratory abnormalities, were urinary frequency, urinary tract infection, dysuria, micturition urgency, decreased hemoglobin, increased lipase, urinary tract pain, decreased lymphocytes, hematuria, increased creatinine, increased potassium, increased AST, decreased sodium, bladder irritation, and increased ALT. Use in specific populations. Pregnancy. There are no available data on the use of INLEXZO in pregnant women to inform a drug-associated risk. Please see embryo-fetal toxicity for risk information related to pregnancy. Lactation. Because of the potential for serious adverse reactions in breastfed infants, advise women not to breastfeed during treatment and for 1 week after final removal of INLEXZO. Females and males of reproductive potential. Pregnancy testing. Verify pregnancy status in females of reproductive potential prior to initiating INLEXZO. Contraception. Please see embryo-fetal toxicity for information regarding contraception. Infertility, males. Based on animal studies, INLEXZO may impair fertility in males of reproductive potential. It is not known whether these effects on fertility are reversible. Geriatric use. Of the patients given INLEXZO monotherapy in Cohort 2 of Sunrise 1, 72% were 65 years of age or older, and 34% were 75 years or older. There were insufficient numbers of patients less than 65 years of age to determine if these patients respond differently to patients 65 years of age and older.
Here we will discuss the dosage and administration with respect to the urinary catheter. INLEXZO is co-packaged with a sterile urinary catheter and a sterile stylet required for transurethral insertion into the bladder. The urinary catheter and stylet are made of thermoplastic elastomer and polyethane and consist of the following components: a semi-transparent urinary catheter with a rounded blunt distal tip that includes a coude tip, a product exit port near the distal tip, and a lumen which extends from the exit port to an open proximal end. A green stylet with a hub at the proximal end is used to advance INLEXZO through the urinary catheter lumen and into the bladder. Let's transition now to talk about important patient counseling information. Instruct patients to drink approximately 1,500 milliliters or 6 to 7 cups of fluid per day during therapy with INLEXZO. This helps ensure adequate urine production for drug release. Instruct patients not to empty the bladder immediately prior to the insertion procedure. The presence of urine in the bladder can facilitate deployment of INLEXZO. Patients can resume micturition after the insertion procedure. Since INLEXZO contains a hazardous drug, there are some important instructions to patients regarding the handling of urine. Advise the patients to avoid contact with urine while INLEXZO is indwelling in the bladder for approximately 3 weeks and for at least 24 hours post-removal. During the indwelling period of approximately 3 weeks, advise patients to avoid urine sitting on a toilet, to wash hands with soap and water, to wash their genital areas with water after each urination, and to flush the toilet after use. Advise patients to wash clothing soiled with urine promptly and separately from other clothing. Inform the patient that INLEXZO can only be safely scanned with MRI under specific conditions. Instruct patients who will have an MRI to tell their healthcare provider that they have INLEXZO. This information is included in the MRI safety information card. Complete the MRI safety information card and give it to the patient. Patients are not required to disinfect voided urine with bleach, flush the toilet several times after use, or avoid intercourse and oral sex for 2 to 3 days after each treatment. Now we will move on to discuss storage, handling, and disposal of INLEXZO. INLEXZO is the only FDA-approved intravesical product for BCG unresponsive NMIBC with CIS that is off the shelf and stored at room temperature. Store in the original carton at 20 degrees Celsius to 25 degrees Celsius. It is also important that INLEXZO does not require any special preparation prior to use, such as refrigeration, reconstitution, or use of a hood. As noted before, INLEXZO is a hazardous drug. Follow applicable special handling and disposal procedures while handling INLEXZO and during the insertion and removal procedure. The carton includes 1 sterile single dose of INLEXZO co-packaged with 1 sterile urinary catheter and 1 sterile stylet. Now we will move on to discuss INLEXZO support. The slide here will highlight access support for INLEXZO procurement. Johnson & Johnson is committed to ensuring INLEXZO fits into your practice. There are dual procurement pathways that allow for purchase of INLEXZO your way, with specialty pharmacy, fulfillment through a Credo for a tailored patient support, or specialty distributor, procure from our list of trusted specialty distributors. J&J is committed to providing a dedicated account team. Your oncology team at Johnson & Johnson is here to assist you and your patients. Your team of sales representative, clinical educator, field reimbursement manager, account manager, medical science liaison are all on board to provide support. And finally, access resources. There are tools and resources designed to educate and simplify the reimbursement process. These include access and reimbursement guide, how to order guide, coding flashcards, and in-office billing and coding support. Johnson & Johnson is committed to providing you with reimbursement information for INLEXZO. The access and reimbursement guide can provide important product information, coverage and coding considerations, sample claim forms, reimbursement support resources. Please scan the QR code on the slide to display the access and reimbursement guide on your device. Now let's discuss access support, patient treatment journey. Once you've made the clinical decision to prescribe INLEXZO, Johnson & Johnson has resources to help you support your patients. J&J with Me is comprehensive support throughout your patient's treatment journey. J&J with Me is your single source for access, affordability, and treatment support programs from Johnson & Johnson. Your patients will be connected to INLEXZO with Me. There is access support to help navigate payer processes. This includes insurance coverage verification, benefits investigation support, prior authorization support, exceptions and appeals process support, reimbursement information. J&J with Me provides affordability resources for your patients. This is designed to help patients discover ways to afford INLEXZO, regardless of their insurance type or even if they have no insurance at all. And finally, dedicated, free, one-on-one support for your patients throughout their treatment journey. Patients will partner with their care navigator, who is an oncology-trained nurse, to schedule phone calls during key milestones in their treatment. The patient support and resources provided by J&J with Me are not intended to give medical advice, replace a treatment plan from the patient's healthcare provider, offer services that would normally be performed by a provider's office, or serve as a reason to prescribe INLEXZO. Care navigators do not provide medical advice. Let's discuss affordability support patient costs. When you have made the clinical decision to prescribe INLEXZO, Johnson & Johnson has resources to help you support your patients. The table below illustrates cost support options regardless of insurance type. First up, commercially insured patients, J&J with Me Savings Program. Eligible patients pay $5 per treatment for INLEXZO out-of-pocket treatment costs and pay $0 for certain treatment administration costs. Maximum program benefit per calendar year shall apply. Offer subject to change or end without notice. See program requirements at inlexzo.jnjwithmesavings.com. Now let's discuss government coverage, Medicare, Medicaid, military, foundation support, and advocacy. J&J with Me can provide information about resources that may help your patients with their out-of-pocket treatment costs. These include state pharmaceutical assistance programs, SPAPs, state health insurance programs, SHIPs, Medicare savings program, independent sources of support, finally, patients with no insurance, affordability support for patients without insurance coverage. J&J with Me can help identify other resources that may help your patients with out-of-pocket treatment costs. Call 833-J&J with Me 1 or visit jnjwithme.com for information on affordability programs that may be available. The patient support and resources provided by J&J with Me are not intended to give medical advice, replace a treatment plan from the patient's healthcare provider, offer services that would normally be performed by the provider's office, or serve as a reason to prescribe INLEXZO. Independent copay assistance foundations have their own rules for eligibility, which are subject to change. We have no control over these independent foundations and can only refer your patients to a foundation that supports their disease state. We do not endorse any particular foundation. As we wrap up, let's look at the INLEXZO summary. In summary, INLEXZO is designed for patients seeking bladder preservation. INLEXZO demonstrates an 82% complete response rate, and 51% of patients maintained a complete response rate for 12 months. INLEXZO has a proven safety profile. The two most common adverse reactions were urinary frequency and urinary tract infection. 24% of patients had a serious adverse reaction. 7% of patients permanently discontinued due to adverse reactions. Dosage interruptions due to adverse reactions occurred in 41% of patients. INLEXZO provides prolonged local delivery of gemcitabine into the bladder. It is also practice-changing in that it is an off-the-shelf product, stored at room temperature, and no special preparation is required. The procedure is done via catheterization and cystoscopy, which are familiar in your practice. Based on this, consider choosing INLEXZO first after BCG in your appropriate NMIBC patients. This video explains the preparation, insertion, removal, and disposal of INLEXZO.
This video guide explains the preparation, insertion, removal, and disposal of INLEXZO, gemcitabine intravesical system. Before beginning, gather all necessary supplies. The product carton contains 1 sterile INLEXZO, 1 sterile urinary catheter, and 1 sterile stylet. Check that the expiration date is valid. and examine the packaging thoroughly for cuts, tears, or punctures. Gloves are not included. Since INLEXZO is a hazardous drug, wear gloves and take appropriate precautions. If contact is suspected, immediately wash with copious amounts of water. Advise patients and caregivers to exercise caution when handling urine during indwelling period of approximately 3 weeks. Always maintain aseptic technique to help prevent infection. Prior to opening the foil pouch containing INLEXZO, prepare 2 10 milliliter syringes, each filled with 2 to 3 milliliters of sterile, water-based lubricant, plus additional lubricant for urinary catheter tip lubrication. Syringes and lubricant are not included in the carton. Carefully open the outer foil pouch and remove the inner pouch. Since the outside surface of the white inner pouch is not sterile, it should not be placed on a sterile work surface. At this stage, the INLEXZO pouch and the urinary catheter and stylet pouch are placed on a non-sterile field. Using aseptic technique, gently open the pouches and transfer contents onto a sterile surface. Wearing sterile gloves, remove the plastic sleeves from the ends of INLEXZO and inspect the urinary catheter, green stylet, and outer surface of INLEXZO. Inspect the components for signs of damage. If the packaging or components are compromised, do not use. Lubricate the tip of the urinary catheter without the green stylet and gently introduce it into the urethra by hand. Advance the urinary catheter until urine return. Do not empty the bladder. Use the depth markings as a guide and do not excessively force the urinary catheter into the bladder. In case of resistance, careful assessment and standard procedural techniques can be performed as appropriate in order to safely advance the urinary catheter into the bladder. If advancement is obstructed or cause cannot be determined or resolved, withdraw the urinary catheter to avoid patient injury or urinary catheter damage. Do not reuse urinary catheter. Once the urinary catheter is in place, use the first lubricant syringe to inject 2 to 3 milliliters of lubricant into the end of the urinary catheter. Now, insert either end of INLEXZO into the urinary catheter and advance by hand until it is fully inserted. Using the second syringe, inject an additional 2 to 3 milliliters of lubricant to help advance INLEXZO further. Slowly insert the stylet into the urinary catheter until the hub is flush with the end, ensuring INLEXZO exits the urinary catheter and enters the bladder. If INLEXZO cannot be advanced, remove urinary catheter and stylet together as a single unit and begin again by obtaining a new carton of INLEXZO, including a new urinary catheter and stylet. After successfully inserting INLEXZO into the bladder, remove the urinary catheter and stylet together as a single unit. INLEXZO should remain inside the bladder. Inform the patient and caregivers that INLEXZO will remain in the bladder for the indwelling period of approximately 3 weeks. Advise the patient and caregivers that INLEXZO contains a hazardous drug, and they should therefore exercise caution when handling urine during the indwelling period. Since INLEXZO contains a metal wire, MRIs can only be performed under specific conditions. Complete the MRI safety information card and provide it to the patient. Advise the patient to show the card to their healthcare providers if they need to undergo an MRI. To begin the post-treatment removal process, lubricate and insert a cystoscope into the bladder to locate INLEXZO. Using non-cutting, grasping forceps, carefully grasp INLEXZO over the tubing and metal wire, avoiding the ends. This is done to avoid exposure of the metal wire, thus minimizing risk of potential tissue damage. Remove the cystoscope and forceps together from the urethra, removing INLEXZO under direct vision. Do not attempt to remove INLEXZO through the working channel of the cystoscope. After removal, inspect INLEXZO to confirm it is intact and not broken. Dispose of the used urinary catheter and style it. INLEXZO and its packaging per facility procedures and per applicable federal, state, and local regulations. Do not re-sterilize or reuse the urinary catheter. Reuse can lead to its degradation, failure, and contamination, which can increase the risk of infection or transmission of bloodborne pathogens to patients and users. Thank you for watching this video guide.
Thank you for your time and attention in watching this presentation. The QR code shown here will direct you to our HCP website and a link to the order of the operations video you just saw. Thank you.